At the beginning, I would like to thank the International CML Foundation for the kind invitation to give this talk on the non-BCR-ABL molecular biomarkers of prognosis in CML. I have no relevant disclosure. So CML has been considered for a long time as a prototype model of cancer evolution on top of a single oncogene, which is BCR-ABL. This is supported by the presence of BCR-ABL in all CML cases and by the high response rate of CML patient to the BCR-ABL targeting tyrosine kinase inhibitor treatment. So is it real that CML is a one oncogene show? Indeed, the heterogeneity of the clinical outcomes of CML patient in response to TKI treatment suggests the contribution of BCR-ABL independent mechanism. A proportion of CML patients on the TKI treatment develop resistance to the treatment, while ABL1 kinase domain mutation can explain most of the secondary resistant cases. The mechanisms underlying the primary resistant cases and some of the secondary resistant cases remain elusive. Additionally, a minority of CML patients on TKI treatment progress from the chronic phase to the aggressive blast phase with very poor prognosis and fewer treatment options. Thus, there is a need to characterize such BCR-ABL independent mechanism and identify biomarkers that can predict such adverse events. On the other hand, with the major improvement in the CML outcome induced by TKIs, there has been a new goal of CML management that emerged, which is successful discontinuation of the otherwise lifelong TKI treatment in patients who are achieving and sustain deep molecular response. Identification of biomarkers that can predict these deep molecular responses or DMR and achievement of treatment-free remission or TFR is of great interest to the current clinical CML practice. The features of the ideal biomarkers in relation to the recent or the latest ELN recommendation have been summarized by this review by Krishnan et al. This ideal biomarker should be able to predict disease progression, treatment resistance, and achievement of treatment-free remission, as well as guiding patient stratification and treatment selection. So there has been a growing evidence on the genetic heterogeneity of CML patient at both phases and the potential impact of these mutations on the clinical outcome. About 1/3 of chronic phase CML patient and 80% of blast phase CML patient have been shown to harbor at least one mutation in a cancer-associated genes. In addition to the ABL1 kinase domain mutation, blast phase show abundance of known leukemia-associated gene mutations such as RANX1, BCR-L1, ICR-Zinc-Finger1, and other mutations. While on the other hand, the mutation in the epigenetic modifier genes such as ACXL1, CETID1B, TET2, DNMT3A were abundant in both, comprises a major subset of the mutation in both phases. So let's start with the chronic phase. And this is study by Kim et al. From the University of Toronto. They have done a deep targeted sequencing of samples from 100 chronic phase patient, both at diagnosis and later follow-up time point. But 37 patients have been shown to harbor at least one mutation in a known cancer-associated gene. Most of the identified mutation belong to the epigenetic modifier gene family. It has been shown that these mutations were more frequently encountered in about half of the patient from the resistance and progression group, in contrast to 25% of the patient from the responsive group. This has been also shown by the following studies who have shown that there is accumulation of genetic aberration in patients who are resistant treatment or progressing to blast phase. So in Kim et al. Study, they have shown that mutation in the epigenetic modifier genes were associated with less probability to achieve milestone molecular responses. Interestingly, a study by Nitolopoulos et al. From Imperial College have shown that this mutation inferred negative effect were clear in imatinib treated patient, but not in patient treated with second generation TKI, suggesting a potential value of the mutational data in treatment selection. So it is noted that many of the frequently mutated genes in the chronic phase, such as A6L1, TET2, DNMT3A, are also known clonal hematopoiesis-related mutation, which is kind of expected given the elderly onset of CML. The presence of CHIP mutation in an pre-leukemic and Philadelphia negative clone have been previously described and being shown to be associated with various pattern of clonal evolution and treatment outcomes. However, the actual contribution of the CHIP to CML pathogenesis remains unclear given the CML-specific CHIP profile compared to healthy elderly and other myeloid neoplasm, as well as the abundance of these mutations, such as the A6L1 mutation, also in pediatric CML patients. A recent study have shown that there is no age difference between A6L1 mutated and non-mutated CML patients. So further studies, especially single-cell analysis, can clarify the potential contribution of the CHIP to CML pathogenesis. So if it starts to feel a bit complex, the mutational profile of chronic phase patient, then it is expected to be way more complex and heterogeneous the mutational profile of blast phase patient, where the progression process is attributed to an active process of acquiring mutations due to the genomic instability state induced by the BCR-ABL itself. It has been shown that there is abundance of non-leukemia associated genes, such as RUNX1, BICR, TB53 mutation, but there is also identified CML-specific mutations such as UBE2A and CITID1B, which are frequently acquired during the disease progression. A study by Autry et al. in Nature Communication have shown different pattern of clonal evolution during the disease progression, where we can see that some of the mutation have a clear driving effect, such as RUNX1 and B53 mutation, while other mutation have a mixture of effect, such as the A6L1 mutation, which can be either acquired, lost, or being stable during disease progression. They have also interestingly shown a predictive value of the genetic aberration in blast phase patient, especially the A6L1 mutation and the CNV changes in predicting survival in the TKI treated patient. Another class of mutation is the fusion genes and rearrangement. Branford et al. Study have described this, what is called Philadelphia-associated rearrangement, which are rearrangement in the translocated chromosomes 9 and 22, which are formed by fusion or rearrangement of the gene during the formation of the Philadelphia chromosome. These were more frequently encountered in poor outcome patients. The presence of either or both cancer-associated mutation and the Philadelphia-associated event were associated with increased probability to progress to blast phase, resist treatment, acquire ABL1 kinase domain mutation, and failure to achieve milestone molecular responses. In addition to that, the well-known leukemia-associated fusion genes such as inversion 16, CBFB, MYH11, and RUNX1 fusions have been also described during disease progression. Well, as we can see, the heterogeneity of the mutational profile hinders a straightforward interpretation of the genetic data and makes it necessary to identify or differentiate between passenger and driver mutation. The transcriptional data allow further refinement of the mutational data and it gives insight into the actionable contribution of genetic and epigenetic aberration. We can see from this timeline many studies that have aimed to identify a gene expression-based classifier model or gene expression signature that associate with either treatment resistance or disease progression. Well, it is notable the heterogeneity between these CML transcriptional study regarding the source of the sample, whether peripheral blood or bone marrow, whether selection of the sample or the population selection, whether CD34 positive cells or unselected samples, the applied platform with the microarray or RNA sequencing, as well as the size of the suggested gene expression signature, ranging from few genes to thousands of genes. This is making cross-validation of the results and the data a bit challenging. Only few studies have done such cross-validation, such as the study by Ko et al. In Blood 2021, which have done cross-validation with 2 previous studies that have used the same cell population, CD34 positive selected cells. Further standardization of the method and data harmonization are warranted before the possible clinical application of the molecular data. With the advances in the sequencing technology, single-cell RNA sequencing have been introduced into CML's field by these 2 landmark CML studies. In the first study from Göran Carlson lab, Sweden, they have combined single-cell RNA sequencing with flow cytometry to delineate the heterogeneity of leukemic stem cells in CML. And they have identified a subpopulation of leukemic stem cell which persist TKI treatment, and they have done thorough characterization of these cells both phenotypically and transcriptionally. The other study, similarly from Adam Mead's lab, they have done similar transcriptional analysis of leukemic stem cells, and they have applied this SmartSeq2 platform, and they could also identify this quiescent leukemic stem cell enriched stemness signature that can persist TKI treatment. They have interestingly show a predictive value of the single-cell RNA sequencing data related to prediction of achievement of major molecular response, and also identification of leukemic stem cell with blast phase-like signature already in the chronic phase sample from a patient who later progressed to a blast phase. An example of the value of combining mutational and transcriptional data as well as cross-validation studies is the role of FRANX1 in blast phase CML. FRANX1 is one of the most frequently mutated genes during disease progression. We have shown in our lab that that blast phase patients with FRANX1 mutation have a distinct phenotypic and transcriptional profile, which is characterized by upregulation of stem cell and lymphoid markers, as well as activation of specific signaling pathway. Interestingly, this FRANX1 specific gene expression signature was recently validated and further refined by this study published 2022 in Leukemia from Onk's lab, that showed the consistency of this FRANX1 specific signature across blast phase patient. This is of particular interest because we have shown that the FRANX1 signature, transcriptional signature, was translated into specific and newer treatment options, such as the immunotherapy, treatment with CD19 CAR T cells, and sensitivity to targeted therapies such as VEGFR, BCL2, and mTOR inhibitors, which can potentially improve the outcome of blast phase patients. Okay, in all of the previous part, I was talking about the traditional outcomes or the traditional goal of CML management related to survival rates, disease progression, treatment resistance, and biomarkers related to that. But what about the new goal of CML treatment, which is the achievement of deep molecular remission and treatment-free remission? It has been shown that the predictive value of mutational data, especially germline ASXL1, BIM1, BIM mutation, as well as HMG CLL1 polymorphism related to achievement of deep molecular responses. It is noteworthy to say that this ASXL1 mutation and BIM mutation, the predictive value of this mutation in relation to deep molecular response were only seen in imatinib treated patient, and again not in second generation treated patient, in this case nilotinib treated patient, suggesting again a role of mutational data in treatment selection decision. More recently, Radich lab have identified this gene expression signature based model with high efficiency in predicting the lead molecular response achievement. Another example or another study came from our lab more recently, which showed the potential predictive value of mutational data in relation to achievement of treatment-free remission, especially the epigenetic modifier gene mutation. We have screen sample, diagnostic sample from 47 chronic phase CML patients who later attempted TKI stop. We have identified cancer-associated mutation in 12 of those patients. And we have shown that the presence of epigenetic modifier gene mutations were more frequently encountered in patients who relapsed after TKI stop in 8 out of 30 patients, in contrast with only 1 patient out of 17 patients who sustained treatment-free remission after TKI stop. The presence of mutation in epigenetic modifier genes at diagnosis were associated with worse relapse-free survival rates with a hazard ratio of 3.6 in contrast to patient who doesn't have the mutation. We have also provided an interesting link between the mutational data, especially the relapse associated mutation, in this case KDM6A mutation, and the impaired immune response in CML. We have shown that knocking out KDM6A in K562 cells were associated with reduced NK cell NK activation and NK-induced cytotoxicity, which potentially refers that the impact or the relation between the mutation and the possible changes in the immune regulation. It is well known that immune regulation is suggested to play an important role in achievement of TFR. So finally, I have been showing in this presentation the growing evidence on the predictive value of molecular biomarkers on non-BCR-ABL molecular biomarkers in CML. However, there is still many open questions and challenges to be addressed before the possible clinical application of these molecular biomarkers. International collaborative studies are warranted to address these questions and optimize the usage of molecular data. Further standardization of the method, harmonization of the data, and cross-validation of the results, as well as clinical assessment of these biomarkers are needed before the possible clinical incorporation of these genetic biomarkers in the CML management, where it can be combined with the currently used clinical scores such as SOCAL score and ELTS score to improve the predictive value of these scores, which have been already shown by some studies. Finally, I would like to thank all my colleagues in Professor Satomo's Tioki lab, the University of Helsinki. I'd like to thank all our collaborators and funding authority, and of course, our patient, and thank you for your attention.